Welcome back to another episode of The Learning Curve. I am your host, Irtaza Asar, and today we're going to be diving into one of the most uncomfortable and yet most important realities in medicine, uncertainty. We spend years training to find the answer, to make the right call, to project confidence. But what happens when there isn't a clear answer? As clinicians, we're wired to solve problems. But clinical care isn't always a straight line, and sometimes the hardest skill to master is the ability to be okay with not knowing. In today's episode, we're talking about the art and science of managing diagnostic uncertainty, and more importantly, how we can teach our students and residents to embrace the unknown without losing their confidence, their compassion, or their critical thinking skills. I'm thrilled to be joined today by Dr. Craig Brewster. He is a practicing emergency medicine physician at Aurora Hospital in Wisconsin, and today he's going to help us navigate these uncharted waters and give us a lot of great guidance. Craig, thank you so much for joining me.
Yeah, thanks for having me on.
Hey, this is going to be a fun episode. And I don't know, Craig, if you've seen any of the other episodes, but every single guest that I've had on, they've had like a unique skill set from rapping to beatboxing to baking. So Craig is a multi-talented man. I've known him for a long time, so I'm excited to share that he is a board game connoisseur. So if you have a specific board game in mind, he's definitely your go-to guy. Craig, what's your favorite board game right now?
Oh man, right now we've been doing actually card games. Something called Skull King is what my family's been into. Yeah.
Cool. That sounds really cool. What's that about?
So it's like a trick-taking game. If you've ever done trick-taking, basically you start out with one card and then you work your way up to 10 different cards, and you have to lie and best your way up to the most amount of points you can get to win it.
Cool. That sounds awesome. And I think that's actually a really great segue into diagnostic uncertainty. Awesome. So, Craig, let me pick your brain about this and let's set the stage for this conversation. What is diagnostic uncertainty?
I think there's a lot of different ways to describe it. I think one of the ways that I would go about it is with starting with one of my favorite quotes. And it initially given by Socrates. Actually, Plato was the one that attributed it to Socrates, but the only true wisdom is in knowing you know nothing. And I think more succinctly said by someone called Adam Grant is, if knowledge is power, knowing what we don't know is wisdom. And so diagnostic uncertainty, I think, is someone comes into the emergency department and they're here for chest pain. We see this is bread and butter. We see this day in, day out. We do our workup, everything comes back negative. We're like, well, everything looks good, but we don't know why you were having this chest pain. And kind of go into that quote is, knowing what we don't know, we're not sure what's causing it, but we have the experience to know that, well, it's not this particular scenario we don't think is life-threatening, or maybe the reverse is true and we don't know what it is, but we're worried, we're concerned. There's something else going on in the background, something, maybe with their vitals or just something with the story, catches our interest, and we're like, well, this needs further workup. But these are things that we see as emergency physicians day in, day out, and we have to be comfortable with it. And it's not something I feel like in residency that we get a lot of training on or we talk about enough, and it's something that we're expected to get afterwards through experience.
Yeah, and I think that's actually the exact same framework that I've really tried to tackle diagnostic uncertainty with. How I define it is more so as a gap between what information I have access to me and the diagnostic clarity from which I'm presenting to a patient. So I think that framework that you're looking at, I think is perfect. And it's the same way that I approach diagnostic uncertainty, because in my mind, a lot of what we get training on is trying to find the answer. What ends up happening in diagnostic uncertainty is you've done the workup, you don't really have an answer, and now you're like, oh man, what do I really do? And that's a conversation that we're really going to have throughout this episode about why we feel this way and how we can address that to really help our younger learners that are out there. I've noticed that from my standpoint, diagnostic uncertainty is really common, especially early on when you have that critically ill patient. You're not really sure why they have this, let's say, undifferentiated shock, or you have a really complicated polytrauma patient that you're trying to work through multiple different systems, or when you get a lot of conflicting data, and we'll give some examples of that as we progress throughout this episode. I think one of the key things that is very important to stress is that this is not really a failure. It's almost like a natural part of taking care of patients, is that you get this information, get sometimes information overload, sometimes you don't get enough information, and a combination of all these things can really cause this diagnostic uncertainty. From your standpoint, why is it that you think it makes us feel so uncomfortable? I'd love to get your insight on that.
Well, I think there's a lot of different reasons why it makes us uncomfortable. Part of it stems from this culture that comes up. We start, maybe in our undergrad, that we always need to have the right answer. You start taking tests, medical school. It's all about tests. It's all about getting the right answer. It's all about go through your clerkships and an attendings ask, look at this EKG, tell me what is the arrhythmia, when you have to give an exact answer. And if you're wrong, then you have to go look it up, do more. And so when we get these patients, while certainly we want to be educated in terms of working these patients up and doing the correct test, sometimes no matter what we're going to do, we're just not going to have the answer right away necessarily. In an ideal environment, the emergency department, hopefully we're only having these patients for maybe a couple hours in the ED. That's not enough time to have every scenario played out, to have every test done, and to fully understand, what's going on. Our job is to try to stabilize these patients as best we can and then direct them to the right area, whether that's to the ICU or to a observation bed, or whether that's some outpatient follow-up.
That's actually a really great point. And when I was prepping for this episode, I was doing a lot of internal reflection, and the exact point that you brought up kind of echoed with me as well, is that throughout our training, we're really focused on diagnostic certainty. So like that multiple choice question, there's only 4 options, right? There's not a 5th option, unless obviously you have 5 options, but really you've got 4 choices. You got to pick one. One of them is the right answer. And you don't really get that open-ended question that promotes critical thinking. So I think that's actually a really cool point. I've also found that sometimes learners feel that, hey, if I don't know the answer, it's going to make me look incompetent. And that's one of the cultural things that I've noticed, especially with a lot of junior learners, where they don't know what they don't know. And that drives that fear in them that, hey, listen, I'm really afraid to make mistakes. I remember my first week as an intern, I had an incarcerated hernia. My attending came out and was like, hey, how could you not know that? And I was like, I've never actually physically seen one. I didn't know what that actually looked like. It's like good for me to know. And then from that stems this fear of being judged or making mistakes in medicine. Something that I think we've gotten better at, but I think we still need to do a lot more work at, is trying to acclimate ourselves to being okay with being wrong and being willing to learn from those mistakes. That can help us start to tackle some of the challenges that come with addressing diagnostic uncertainty. So having laid this groundwork, Craig, can you talk to me about certain examples that we commonly see from an emergency department standpoint that really showcase this idea of diagnostic uncertainty?
Yeah, I mean, there's the classic example that we hit upon already is the 50-something-year-old coming in for chest pain. Started 3 hours ago. He was at rest. Maybe he has some risk factors like high blood pressure, high cholesterol, that type of thing. And you do your workup, and I think most places nowadays are using like high sensitivity troponins, and so you're getting your 2-hour repeat troponin, and everything comes back and it's negative. And you've done your good physical exam, you've checked everything out, vitals look good. Maybe his pain's resolved ideally, and when you're like, well, I'm not sure what's causing it. What are you going to do? Other things are abdominal pain. You get your 76-year-old patient, you have somebody coming in for abdominal pain, generalized. There's no focal findings. Again, everything comes back negative. And you can have the same scenario, take it in like a 30-year-old, but obviously you're going to have different concerns based on the age. And these are things that we see day in, day out. I mean, I don't know about you, but multiple times per shifts, I'm seeing these people and I'm going, well, I'm scratching my head. I'm not sure. Everything looks good. Follow up.
Yep. My personal favorite is the old lady with dizziness, which
Your favorite. Oh my gosh.
and I think that's the one I think gets a lot of people too, where it's like, oh my God, man. Yeah, you're like 86, you have 8 million comorbidities listed in your chart, and
They're
you're
on
here
like
with
12
dizziness.
beds.
Yep. Yep. Those are the patients where you get the workup back and everything is done and everything's situated, everything looks okay. But the question is, where do you go from there? How do you
Right.
frame that conversation? What's
Absolutely.
the next step? Is this somebody that needs observation?
It depends on the hospital that you're training at too, right? I mean, some of us train at academic, tertiary care centers. Some of us, like you and I were at, community centers, but a lot of us are going to go practice in rural places or in smaller hospitals. And the dispo of where these patients go, that dizzy person that comes in, is a lot of it's going to depend on the institution you're at, but also the thing that I think we sometimes don't necessarily, either we don't have time or we kind of forget to do, is looking at where is this patient going when they go. If they go home, what is it they're going home to? Are they by themselves? Do they have anybody to help take care of them at home? Is it just them and their cat? Or what's the scenario? And that's a huge part of our job. especially with these unknown cases.
Yeah, and I think that's a great point. I'll should bring up an example later on in the episode when we talk about trying to tackle and navigate our learners through diagnostic uncertainty. But I think that's actually a really fantastic point. One thing I've noticed in my career, especially early on, is that I tend to do a lot more shared decision making when I'm at sites that are more rural, because a lot of these folks are not inclined to being transferred. They're like, hey, listen, I've got to take care of my kids. I don't have social support at home. I'm taking care of my loved one. I don't have transportation. If you send me to a bigger site, I have no means of getting back. So in those patients, I've noticed that I've been doing a lot more shared decision making, and I think that's been very helpful. But you're right. I do think that does kind of influence your practice patterns depending on the site that you practice at, whether it's academic or you're at a facility that has a lot of observation capabilities, that has a lot of specialist support where you could try to get some of these workups started. But if you're working in a more rural setting, you really have to make challenging decisions, I feel, in
Yeah.
terms of how to navigate some of these patients and the pathology that they present with. So I think that's a fantastic point. So let's shift gears a little bit. We talked a little bit about how learners experience diagnostic uncertainty, but I just wanted to get your perspective on why you think students and residents tend to struggle with this. I think we talked about it a little bit, but I want to talk about that in relation to some of the realities that we're dealing with in modern medicine. So can you give me your thoughts on this issue?
Yeah, I'm going back to one of the points we made. I mean, a lot of it is from just the expectation, I think, that we come into medicine thinking that we need to know everything. I mean, it's not only is it the expectation that we place on ourselves to know everything, but patients. We see these patients and they come into us at their most vulnerable time and they want to know. And you're talking with them, their family, and their expectation is that they came here and you're going to tell them what is wrong. And I think that, especially as young students or residents or young attendings, we go into that room and we don't know the answer that they're looking for or that brought them in. It makes us feel like we failed them. And in reality, I have a spiel that I tell a lot of my patients that looks for the big, bad, and the ugly things when I'm trying to rule out these types of things for you. And I haven't found anything that looks life threatening at this point in the workup. And it's such a difficult topic to teach to students and to residents. I think when we get outside of those areas, it just becomes super uncomfortable for us. And I think having these frank discussions, having it with our attendings, having it more of an open process, allowing the learner feel more comfortable coming to them and saying, hey, I don't know, I'm not sure what's going on. They could say, instead of coming out of the room and being like, what do you think the diagnosis is? Or what's your differential diagnosis? Instead, say, what are you unsure of in this case? What are the things that you don't know that are bothering you?
Yeah, and I think that's actually a really cool point. That's something that I've tried to build into my own habits as an educator. Some of it also stems from us, is that if we also show to our learners that, hey, there's a certain vulnerability that comes with this, that we're at risk of facing diagnostic uncertainty on a daily basis as well, I think that almost normalizes it for them. So one of the things that I've gotten in the habit of doing is that if my learner comes out of a room and says, hey, listen, I'm not really sure what's going on, I go in and I feel the same way with them and I'll say, hey, listen, I'm not really sure what's going on, but let's say this is their primary complaint. Let's do this workup first. Let's see what we find. Let's try to get more collateral information, because ultimately we're both in the same boat right now and we're navigating these uncharted waters. So let's navigate them with the tools that we have at our disposal. Let me teach you how to use these tools to help you get that answer. One of the things that I think is challenging about modern day medicine that really also makes diagnostic uncertainty more difficult for our younger learners, and I think you echoed this point as well, is that families have these expectations and their expectation is, hey, I'm here to find out the answer today. My expectation is that you'll be able to help me get to the bottom of this. And I think trying to set those goals and expectations in line early on, I think is very, very valuable. The other nuance to this is, I'll be honest with you, in the last 5 years, I think our patients have become even more complicated than they were 10 years ago.
Yeah.
Multiple different comorbidities, multiple different vascular procedures, bypasses, end-stage renal disease, multiple previous infections, several different hospitalizations across several different healthcare systems with different EMRs that you don't have access to those records.
Not to mention all the medication. I mean, there's the new meds, especially like you get these oncology medications. And I don't know about you, but I don't know half of these medications and I have to go look them up and figure out what is going on. And it just creates that level of complexity. Absolutely.
The amount of times I've had to read up on checkpoint inhibitors is too
Yeah.
much.
It takes me
But
back to the med school. Yeah, no.
yeah, what I've noticed is that sometimes you can visibly see your learners struggling, and I think you notice them over ordering tests to try to figure out, hey, I got to try to rule everything else out.
Yeah.
But you don't necessarily need to do that because you have some incredible clinical decision-making tools, and you brought up a great one. PERC is out there. PCARN is out there as well. And that's one where I've utilized very frequently to try to hopefully avoid unnecessary CT scans on a lot of my younger patients. And I think some of this you can also see with younger learners is that they end up getting frustrated and they feel anxiety, they feel disengaged
Yeah.
when it comes to diagnostic uncertainty. But I think a lot of it is more reaffirmation from our standpoint that, hey, listen, this is just normal. We just have to figure out different ways to work around this.
Yeah, absolutely.
So, having said that, let's talk about some different strategies that we can use to basically normalize and navigate diagnostic uncertainty. Craig, can you talk to me about certain strategies that we can employ to help our learners?
Yeah, everybody's going to develop, I think, their own strategies as they get out there in their initial years as an attending. The first thing is to take a step back, I think. You have this patient, you're not sure what's going on. Say, you're working in a busy and emergency department. I work solely nights, so, maybe you're by yourself and it's a busy night. Your nurses are dropping EKGs left and right. When you got this patient, you're like, you're looking at your test, everything's great. You don't know what's going on, but you're like, you're probably going to try to discharge them. Take a step back at that point and go through your differential again. You went into this thinking that this chest pain was going to be ECS. What are some other things that you should be taking a look at? And that's where things like PERC can come in depending on the patient. But in any of these scenarios, learning to go back in your mind and rethink through some of these things, that brings up a point with young learners, especially students and young residents, that you're first out, you get this diagnostic uncertainty. Not only do you have these tools to use like PERC, rely on your physical exam skills too of when you're going through these patients. If you're a student, you definitely need to be honing in on all these skills. And when you're a young attending, you need to be relying on these things to, like you had brought up before, avoiding doing unnecessary tests. There's a clinical tool out there for a lot of things, but sometimes you don't need the clinical tool. You just need to know this is an 8-year-old kid with a cough and a runny nose, and you don't need anything to tell you, they got a viral infection. It's going to take 5 to 7 days and they'll get better.
That's actually a great point. From my standpoint, I think this echoes to the idea of the dual process theory. And this is something that I've gotten in the habit of talking to my learners about. So when I think of the dual process theory, and what really kind of motivated me to start teaching this to my younger learners was this idea that we teach them a lot of medicine, but sometimes what we don't do is we teach them how to think about thinking. And that's kind of where this idea comes from. And like you said, at the end of the visit, you're going back, you're stepping back, you're getting ready to discharge that chest pain patient. And you're thinking to yourself, okay, ACS was my primary differential, but what about certain other things like PE or aortic dissection? Did I consider them? And why do I not think this is that case? And that really helps to set a good framework. So the idea of the dual process theory is that there's type 1 and type 2 thinking. So type 1 thinking is this instinctual thinking. So your example, hey, this kid, I walk in the room, kid looks great. He's got a cough. He's got a runny nose. The kid's going to be fine. Just needs outpatient pediatrician follow-up. It's very instinctual. It's very reflexive. Another example would be is you have that COPD that comes in. You hear wheezing on exam. You're like, all right, put the nebs in. Let's get them situated. So type 1, it's very fast, it's efficient, it gets us through a lot of our shifts in a really reasonable time. It makes sure that we're not being burdened with cognitive overload. Type 2 thinking is the one that I try to tell residents about, is that, hey, sometimes you have to physically tell yourself that, hey, I can't rely on type 1, I have to shift it to type 2 thinking. And that's where it's thinking that's more slowed, it's more methodical, it's more precise. Okay, this patient's here in AFib with RVR. I gave them cardizem. They didn't really respond. Now I'm getting new pieces of information that the patient told me that they were more short of breath the last few days. Could this AFib with RVR be because of a PE? Should I investigate that further? Or you have that patient with a UTI that you've given fluids. Now you notice their pressure requirements are going up. And you're wondering, I wonder why their pressure requirements keep going up. Now I'm on 2 pressors. Maybe I should send them over for a CT scan to check for an infected stone, because clearly I'm not getting source control and they're getting worse. And I think forcing yourself into that type 2 thinking, I think is very, very valuable. You brought up a really great example that I think really echoes that point. And from my standpoint, this is something that I tell residents, is that you can't do type 2 thinking the entirety of the shift, because the problem is it's just too cognitively taxing. So what you have to do is you have to slow yourself down, do type 1, but understand that there is a time and a place where you have to shift yourself into type 2. So I think that's really valuable. One of the other things that I've started stressing to my residents is this idea of an illness script structure, which basically is this framework that I've talked to them about different ways to store and retrieve knowledge about specific diseases. And the idea is that, hey, if you have a disease in mind, you should understand, hey, I understand the pathophysiology. I also know who gets the disease, and I also know clinical data about the disease, specifically physical exam findings, like you talked about, and
Yeah.
also the time course of when it presents. So, like an example of this would be like, let's say aortic dissection, right?
Yeah.
So I have a patient that comes in with aortic dissection, or I suspect aortic dissection. In my mind, now I'm processing, okay, do they have certain risk factors for aortic dissection, like hypertension or Marfan syndrome or some other connective tissue disorder? What was this patient's presentation? Was it acute? Does that fit more line in with an aortic dissection? Does their pain pattern fit in with an aortic dissection? And what are some clinical data that I can use to support and or potentially rule out aortic dissection? Whether that's a CT angio, or I'm looking at the aortic dissection risk score, or I'm looking at some x-ray findings. Can any of those increase or reduce my pretest probability depending on the clinical scenario that I'm in? And I think this kind of chimes into that idea of Bayesian thinking, which again is you have this idea of what you already know, and then the more information that you gather, you're willing to switch it up and basically change those hypotheses as you get more data. And I think that's something that's been really valuable for me as a newer attending, trying to incorporate that, because sometimes you get these almost predispositions about certain patients and you think, okay, this is what I anticipate is their clinical course. And then something happens that doesn't go according to your plan. So you have to immediately shift and build a new prediction or a new theory.
And I mean, things like that, it can be frustrating. I mean, as a clinician, you go in, you see this patient, maybe you think you've seen this particular scenario many times in the past, and you're like, oh, I got this slam dunk, going to be in, out, done. And then things start coming back, or, vital signs start changing, getting worse, and things change, and you have to adjust your thinking. And I mean, it can be frustrating from the standpoint that you thought this was going to go one way, and then it ends up going a completely different way. And you have to be willing, I think, to take that step back and realize, no, my first thought was not right. I need to go back and I need to look at this again. I need to rethink what it's going to do. And classically, it's that last patient you're going to pick up at the end of your shift. You're like, get them in and out, be going home. It's not going to be a big deal. You pick them up and then you talk to because the triage note read as something that didn't seem super. It's like going to be easy. You go in, you see the patient, and nah, that's not the way this is going to go.
Why is that leg necrotic?
Exactly. Yeah, the spider bite on the leg. Yeah. You have to be willing to take that step back and do that. And I think it's important for us to talk to these next generation students and residents, to really focus in on that with them and make sure that they know, sometimes we go in thinking one thing, but it's okay to come back and be like, nah, I was wrong. I need to change what we were doing and go a different direction.
And I think you brought up a really awesome example about discharge vitals, how you're getting ready to discharge. And I can talk about countless scenarios where I'm getting ready to discharge and I'm like, I wonder why this patient is still persistently tachycardic. Maybe there's something else there every time. Yeah. And now I'm like, okay, I have to be flexible. Clearly my initial thought process wasn't right. Maybe I'm missing something else. Maybe I need to think about something else that could explain this finding. And I think that's really valuable. The story that I thought of that I think was a great example of just kind of being flexible. I remember I had this recently older patient that had a ground level fall, had a pretty significant humeral fracture. She was very old, lived by herself. My resident came in, put the splint on, and his plan was to get her back home. And one of the classic. And one of the things that we started talking about is, hey, do you think this is a safe discharge? And his first question was, yeah, I think so. And I was like, okay, my follow-up question to you is, how do you think she's going to do at home? And that's when the light bulb went off. It's like, wait a minute, she can't lift her arm. She lives home alone. She probably can't do any of her ADLs.
Yeah.
I don't think this is a safe discharge plan for her, and I think I might have to get case management involved.
This brings up a whole other, depending on where you work, can bring up a whole other podcast on admitting this patient to your team, hospitalist team, trying to convince them that no, this 3-year-old lady who lives alone can't go home.
Yep. And that's kind of some of the challenges that I think we end up facing. But to kind of piggyback off that, let's talk about how we can create a safe learning environment for our learners with regards to diagnostic uncertainty. So from your standpoint, what are some things that we can be doing to help our learners tackle this?
Well, I mean, I think kind of brought it up, but the first thing is making it a safe learning environment, making sure that we're teaching them that they know that it's okay to bring up the fact that maybe they don't know what the answer is right off the bat. Creating this environment where it's okay to discuss what is it about this scenario that they're like, well, I don't know what it is, but something doesn't feel right about it, and talk about the things that you don't know that are going on. Making sure that you're modeling this behavior for your students and your residents, and doing this moving forward, you're going to see a trickle down effect to these younger generation. I mean, we have seen it in the past, back when residencies and all these things were first starting. We've all heard the horror stories of these residents working 120-hour weeks and just getting completely trashed on by their attendings and coming out just absolutely hating, life. And we've thankfully moved on from a lot of these things, although we've both experienced certain aspects of this and different, rotations that we did in residency. But for the most part, those have changed. I think we just need to keep changing as we're educating people and encourage the idea that it's okay sometimes, that you're not sure what's going on, and then educate on ways to try to mitigate that and to make it less risky for the patient, make the safest scenario as you're going through it.
Yeah, absolutely. And that psychological safety, I think it's so valuable, specifically telling our learners that, hey, it's okay not to know. But what I want you to take away from this is how can we work through this and make sure that we're considering our other diagnoses, or how can we work with the tools that we have at our disposal to help our patients while still creating safe discharge plans, creating safe safety plans, showing them that it's okay. I think it's only going to perpetuate forward to the next generation of learners, like you said, in helping them just being okay with diagnostic uncertainty and being able to handle that. And I think a lot of it stems from us as senior clinicians in being able to model this vulnerability and just showing humility when it comes to this kind of issue. Sometimes as senior clinicians, there's this expectation that, hey, we know everything. When in reality, I think the best clinicians, the ones that I've worked with, that I've learned the best from, are ones that are okay with saying, hey, I don't really know the answer. And that's okay. But what I can show you is how can we work through this? And I think that's really, really valuable. And I think just framing uncertainty as an invitation to really, let's be curious about this and let's collaborate to try to work through this and come up with a plan.
I was just going to say the other part to that is, especially as a young attending or as a resident, knowing when it's appropriate, but knowing that, hey, there are specialists out there that are on call, paid to be on call, and when's the appropriate time to reach out to these people. Sometimes I think we get it in our mind that we should know all this and we don't need the specialist, or we get the idea that the specialists don't want us to call them, but hey, they're there for a reason sometimes, and you need to reach out to them and talk to them.
Absolutely. And I think that collaborative approach can really help, at least also from navigating the conversation with the specialist, just to say, hey, listen, I'm not really sure. I'd like to get your expertise on this, and I want to make sure I'm doing the best thing for this patient. If you lead with that, that also can really help navigate, especially handling some conversations with difficult consultants as well. So I think that's actually a really great point. Just to wrap up, what are some things that we can do to manage risk while also embracing uncertainty from your standpoint?
Well, I mean, a lot of the points that we kind of talked about, making sure that when we walk into the room that we try not to anchor right away on what we think is going on. He sounds wheezy, so it must be COPD, or the patient is dizzy, so it must be some sort of peripheral vertigo, and keeping that in mind when you're going into the room, and then again, stepping back, taking that approach where when you are back at your desk and you've gone through your tests, knowing that you got to maybe take a second, look at it, or take a step back and go through everything in your head again, make sure you're not missing something. Like we've mentioned multiple times, going back to those vitals, look at the monitor. If they're on the cardiac monitor, look at that before you hit discharge. Look at their heart rate, look at their blood pressure, look at, as much as the oxygen isn't even on their finger and it's off, if it's reading 87% though, go look at the waveform, see if it's a good, make sure that you're looking over everything, look at the patient themselves. You thought this was COPD, you gave them all the medications. Do they look better? All these different things before you're hitting that discharge button can really go a long ways. And then one of the biggest things, and this unfortunately I think just comes from experience, but is trusting your gut. If something in your gut is saying, get that CT angio. I've learned in more ways than one, and I'm sure if you speak to a lot of different emergency med docs, they're going to say the same. If your gut's telling you to do something, you probably should follow it.
Your gut's always right. Yep. One of my favorite attendings told me once a long time ago is, hey, if you think about something twice, odds are you should do it. So if you're thinking about getting that CT or you're thinking about getting that Doppler and you've thought about it twice, just get it done. You'll sleep better at night, and I think that'll help you manage the situation better. Some things that I've started to do is getting better at talking about safe netting strategies with my learners. So an example of this would be like, hey, if X happens, I want you to come back immediately. Example would be if you're having a discharge conversation with a patient with cellulitis, hey, if your pain gets worse, I'd like you to come back. Or if this cellulitis rash starts to spread further than the line that I've marked, and it spreads rather quickly in the next 24 to 48 hours, I'd like you to come back. Or if your chest pain gets drastically worse, I'd like you to come back and let us reassess you. And I think that kind of discharge conversation can be really valuable and also give a little bit more assurance to our patients and give them better guidance as well.
Absolutely. I mean, the patients, they, especially if they came in with this emergency concern, they're going to feel, I think, more reassured if we give them very concrete return precautions to the emergency department. They're going to know that we were thinking about them and we're worried, but, let's try this particular treatment. And if things don't go good, then they know that they're welcome to come back. I mean, this can go for any of our patients we're discharging. I always make sure that they know, even the patients that are leaving, maybe against my advice, I make sure that they know that they are absolutely welcome to come back to the emergency department if something changes. And I think it provides you reassurance, knowing that, addressed it with them, that, they can come back, and then the patient feels reassured that it is absolutely okay if I have to come back here.
Yep. One other point that I wanted to echo that I think you brought up a little while ago was essentially having clear follow-up plans for some of these undifferentiated patients, whether that's the patient with chest pain that goes to the obs bed, or this is the chest pain patient that follows up with cardiology within the next couple of days. Making sure that you have a clear line of communication with your family members, with your patients, and having a clear plan. Hey, listen, I wasn't able to get to the bottom of this, but I really think that we can have you follow up with gastroenterology, further work this up, because I do think that there might be something else that I might not be able to find today, but I can tell you today what it's not, so that we can get you on the track to finding what the next approach could be to helping you figure out what's going on.
Absolutely. And I mean, a lot of that goes into some of the shared decision making that you can make with the patients too. I mean, they come in and, whether it's talking about doing a certain test here or follow up, you get that chest pain patient that, maybe he's had a previous heart attack. He's had stents before. Maybe it's been a couple of years though since he's had like a stress test or a cath, and everything came back negative. But was he somebody that maybe want to observe? You talk to him, well, what would you like to do? What would make you feel more comfortable, sir? Talk to him about the different options of, everything looks negative. You could probably follow up with cards in a couple of days, or could watch you here and observe you and, that type of thing. I mean, I don't think you can stress enough the shared decision-making process with patients, getting them involved in their care. I see our job is trying to explain everything as best as I can with my medical knowledge when explaining what different options are, and then getting their input on what the process is, because ultimately it's their care, it's their body.
Yeah, absolutely. Teaching that to learners early on can really help set them up for success, especially coming out of residency training. I think that's very valuable. So, Craig, if I'm a first-time listener and I'm listening for the first time, what, in your opinion, are the 3 key big takeaways that I can take away from this episode?
I think number one would be take the step back before you discharge the patient, looking at the vital signs. I think the other thing would be sometimes you're going to have to be comfortable with the fact that you're not going to know the diagnosis. Be comfortable in the fact that you don't need to order every single test or other tools out there that you can use to, figure out what's going to be best for the patient in terms of, going home versus staying in the hospital. Number 3 is this idea of helping to educate the next generation, making sure that we're passing these things along to the young learners and making sure that we're creating this safe environment for them to learn and to become the best clinicians that they can.
Awesome. And I think those were probably my 3 key big takeaways as well. So for me, I would say number 1 is diagnostic uncertainty is not a failure. It's really an important skill that can help us navigate through complex patients. And that's something that we really can help our younger learners develop throughout their residency training and help set them up for success as attendings. Number 2, as role models, we can really help our learners manage this uncertainty with confidence by showcasing what we do and talking to our residents and our younger learners in a more collaborative approach. That ties into that third point that you brought up, is we really have to work on creating a culture that values curiosity over certainty, because I think that creates a much better learning environment and allows for much safer patient care as well, especially when you end up seeing a lot more complicated patients and you have to make more complicated decisions as well. So awesome. Craig, this was a fantastic episode. Thank you so much for your time. I think there's a lot of great takeaways from this episode. I really do appreciate your time. Any last minute thoughts, any closing thoughts from your standpoint?
Yeah, what I like to compare us to is an air traffic controller. Sometimes we don't know the exact diagnosis, but we're trying to direct these patients into the next best area of care for them, whether that's in the hospital or in follow-up. And going back to one of my favorite quotes, knowledge is power, knowing what we don't know is wisdom. I think I'm always trying to learn new things. I'm always trying to pick up new techniques that can limit this diagnostic uncertainty. But at some point, have to be comfortable in the unknown, and we have to just not let it paralyze us.
Awesome. That's actually a really great closing statement as well. So it's already giving me ideas for the infographics that I'm going to make with Socrates. I think that's going to
Yeah.
be awesome. Yeah. No, that's perfect, man. I really do appreciate your time. Is there any social media where folks can follow you, get your guidance on diagnostic uncertainty?
No, unfortunately, I don't have any social media for them to follow.
Okay, no worries, no worries. Well, Craig, thank you so much for your time. Thank you guys for tuning in. Follow us on YouTube, like us on Apple and Spotify. Thank you guys so much for your time and thank you guys for listening. The question that I would pose to everybody else out there is how have you tackled diagnostic uncertainty and how have you tried to educate learners about being okay and being comfortable with the uncomfortable? Let me know your ideas so we can share them and keep this conversation going so that we can help other learners that are out there. Thank you for another great episode of The Learning Curve. See you guys soon.